So now we'll be starting with the first module on breast surgery. Here we'll be dealing with the concepts of surgical anatomy that will help us in understanding various pathological entities and how we will be able to manage them. Now, breast surgery as a topic is extremely important from the point of view of competitive examinations as well as your professional examinations. Therefore, please pay more attention to this topic and solve the corresponding MCQs as well. Topics that we'll be covering in this module are the anatomy and its applied aspects and the physiology of breast. Now, the key areas from where the questions have been asked from this module are mainly regarding the lymphatic drainage of the breast, and specifically a lot of questions have been asked about the examination favorite topic, that is the Peau d'orange appearance. Okay, now let us delve into understanding what all concepts that we'll be learning today. Now, first of all, breast is a modified sweat gland. That's the first thing that you need to know. It is a modified sweat gland. Okay. Now, extent, when we talk about, we define it from the perspective of few parameters. Vertical extent, it extends from the second rib above to the sixth rib below. Sixth rib below, that is to the inframammary crease. Inframammary crease. Okay. What is the medial extent of the breast? Medially, it extends till the lateral border of sternum. Lateral border of sternum. The lateral extent of the breast is till the anterior axillary line. Anterior axillary or the mid axillary line. Or the mid axillary line. Okay, so this is how the extent of breast is defined. Now, when we talk about the male breast is generally a rudimentary structure, about 2 centimeter in diameter. It lies below the areola and extends till the areolar edge. All right. So, this is about the adult male breast now. Now, we talk about a specific structure which is very important from the perspective of examinations is the axillary tail of Spence. Now, this particular axillary tail of Spence is something which can cause confusion during examinations when you are specifically examining a female who is in her premenstrual period or lactation. Why is this important? Let us understand now. First point about it is that axillary tail of Spence or axillary tail of breast is also known as the axillary process of the breast. Basically, it is the extension of the normal breast into the axilla. Now, extension of which quadrant? We all know that breast is divided into 4 quadrants. We divide the breast generally into 4 quadrants. Okay, this is the outer quadrant, these two, I'll shade it for you. These are your outer quadrants and these are your inner quadrants. Okay. So, this is upper outer, lower outer, upper inner and lower inner quadrant. Okay. So, what is this an extension of? It is an extension of the upper outer quadrant of breast. Upper outer quadrant of breast through an opening in the deep fascia. It is an opening in the deep fascia and the opening is called as, this is a potential MCQ. It has been asked long time back but can be asked again now. It is called as foramen of Langer. Please remember this point. Foramen of Langer is the foramen through which the outer upper quadrant of the breast extends into the axilla. All right. Next point. It is palpable in some women, not in every woman. It is palpable in some women, particularly during 2 times. That is when she is in her premenstrual period or she is lactating. That is when it becomes prominent and it can be palpated. But please remember one thing, that as it can be palpated during these times, it can be mistaken for a mass, it can be mistaken for an enlarged lymph node. Enlarged lymph node, it can also be mistaken for a lipoma. Okay. Now, if it gets involved in breast carcinoma, suppose you have a carcinoma which is not actually palpable in the entire breast, you miss it on examination because it was located in the axillary tail of Spence. You forgot to examine that part of the breast which went right up to the axilla. That carcinoma which occurs, it can be a part or involved in breast cancer, and that cancer which occurs specifically only in the axillary tail of Spence is called as carcinoma of axillary tail of Spence. Tail of Spence. Okay, short form CATS. And what percentage is these carcinomas? 0.1 to 1% of all breast cancers. All right. So, this is also a potential MCQ. What percentage of cancers can be CATS or exclusively in the axillary tail? About 0.1 to 1% of them can be exclusively in the axillary tail. Now, moving on to the embryological development of the breast. When does it start? It starts in the 5th or 6th week of development. This is the first thing to know. 5th or 6th week of development, there is formation of what you call as milk ridges or crest or milk lines. Okay. You can see this is your mammary ridge, also milk or mammary ridges. Mammary or milk ridges. All right, they start becoming evident in the embryo. They start becoming evident in the embryo. Now, in the human embryo, it does not reach up to the groin. It is only present in the upper pectoral region. Upper pectoral region. Okay. And this is what is associated with what we call as supernumerary nipples, or what accessory nipples or supernumerary nipples is because of the persistence of this milk ridge or the mammary ridge. Okay. Now, delving into what structure is formed by the ectoderm and what is formed by the mesenchyme. Now, the ectoderm is responsible for the formation of the ducts and the alveoli. This is an important question, that ducts and alveoli are formed from the ectoderm, whereas the mesenchyme forms your supporting structures, supporting tissue, which includes your vessels, connective tissue. Okay. All right. Now, how exactly does this embryological development takes place? Let us go into it now. First of all, there is a pit which forms, from which forms the first primary bud. Okay, that is the first primary bud, also called as the mammary bud. This is also called as the mammary bud. Okay, this gives rise to 15 to 20 secondary buds. 15 to 20 secondary buds. And these secondary buds are now responsible for forming what? Lactiferous ducts. This is very important, that lactiferous ducts are formed from the secondary buds. Lactiferous ducts. Now, lactiferous ducts go and open into the mammary pit. If you look at this diagram here, okay, this was the mammary pit. There was a bud which was forming, that was the mammary bud or the primary bud, which gave rise to your secondary buds. All right. Now, these secondary buds gave rise to lactiferous ducts which opened into the opening which was called as the mammary pit. Now, The last diagram that you're seeing here is that these lactiferous ducts get elongated to reach above the level of the skin. This was your skin, okay? It went above the level of the skin because of the proliferation of the mesenchyme along with it. So, the level of the nipple rose above the skin, alright, and therefore, there was the eversion of the nipple, okay? So, what we read here is that from the lactiferous ducts which got elongated into the mammary pit, there was formed the nipple, which was because of proliferation of the mesenchyme plus due to elongation of lactiferous ducts. Now, if this pit or the mammary pit fails to elevate or it does not rise above the skin level, what will happen? You will have a condition known as nipple inversion. Very, very important. This has been asked once, that nipple inversion happens because of, and the answer is, it is because of the lack of elongation of the major milk ducts. That is what happens, the milk ducts remain subareolar. Understood? It is not going into the areola, it is going to remain beneath the areola, and therefore what will happen is, towards the opening of the lactiferous duct, it's going to dip inside. Instead of coming above the skin, it is going to dip inside because the lactiferous ducts have remained short, they have not elongated, and that is what is responsible for nipple inversion. One more point here that you need to remember, that nipple inversion has nothing to do with cancer, okay? It is not something that predisposes to breast cancer, and this happens to be your potential MCQ point. Does not predispose to cancer, okay? So, if in a question you are asked which of the following lesions are predisposing to cancer, nipple inversion is not going to be an answer, okay? Does not predispose to cancer, important point. What is the percentage of infants that you come across this abnormality is 4% of the infants, alright? Okay, fine. So, this was about the embryology of breast that you need to remember. These are some points which I have already highlighted for you. Moving on to the next topic is the blood supply of the breast. Now, this is mainly a topic from the point of view of anatomy that you need to know, but here in surgery as well, a question can be asked based on the applied principles of the blood supply, mainly concerning with the mastectomy. But right now, we'll just enlist the blood supply here. First of all, what is the artery that supplies the breast is thoracoacromial artery, which is a branch of axillary artery. Second is from the internal mammary artery, which parts? The perforators, especially the second to the fifth perforators supply the breast. Then you have a supply from the thoracodorsal artery, also from intercostal arteries, especially the perforators of the intercostal artery, and we also get the supply from the lateral thoracic artery. You just need to remember the names here. The details have already been discussed with you in the anatomy modules, okay? Alright, now moving on to the nerve supply. Nerve supply is from the intercostal nerves. Which ones? T3 to T5. And nipple, as you remember, is T4, supplied on the T4, okay? Alright, now moving on to the next topic is, we have read about the location of the breast, we have read about the structures which are responsible for the formation of the breast, that was the embryological development. Now we read about the breast parenchyma. What does the breast parenchyma compose? What is the breast parenchyma made up of? It is made up of two things. One is the ductolobular unit and made up of supporting tissue. Now, this ductolobular is obviously ectodermal. We just read about it. It is ectoderm, and this is from the mesenchyme. Mesenchyme. Okay. Now, both of them are equally important. We read about it. Mesenchyme, when involved, gives rise to certain pathologies which have a very different nature as compared to the pathologies which come out or originate from the ductolobular unit. Now, this is very important from the perspective of differentiating the two pathologies. It is not the same behavior, the behavior itself is different, and if you have the understanding of this concept, it will be easier to understand the pathology as well. Okay. Now, first thing, going into the exact distribution of the ductolobular unit and what exactly are the components, we'll start first with the mammary lobe. Okay. They are 15 to 20 in number in each breast. Okay, 15 to 20 mammary lobe. Please remember the words here, they are very critical. Now, each lobe has 20 to 40 lobules. Okay, 20 to 40. This number is important. How many lobes? 15 to 20 in each breast. How many lobules in each lobe? We have 20 to 40 lobules in each lobe. Then what is important is that each lobule has 10 to 100 acinus. Okay, now look at this image here, you will be able to understand it better. So this is an entire lobe in which you have lobules. These yellow ones are lobules. Extending above the lobules as small pockets are your acinus. Now, from the acinus and from the lobules, you have inside the lobule, you have the intralobular terminal duct, and when it is going outside the lobule, it is called as the extralobular terminal duct. Okay, so we say that the terminal duct is either intralobular or it can be extralobular. Okay, intralobulars combine to form an extralobular unit, which further opens into a lactiferous duct. Which one? Segmental lactiferous, not the main lactiferous. Okay, so how many segmental lactiferous ducts are there? There are about 15 to 20 segmental lactiferous ducts, 15 to 20. Now, these segmental lactiferous ducts further open into main lactiferous duct, and they are about 5 to 9 in number, and this is your potential MCQ point. It is mentioned in Love and Bailey 28th edition that lactiferous ducts are 5 to 9 in number. This can be potentially be a question. Okay, now as many number of ducts, there is a terminal dilation of the duct which is called as a lactiferous sinus. So the number of lactiferous sinus will also be 5 to 9, which open further into collecting ducts, and the collecting ducts finally open into the nipple. So this is how the milk gets formed and it reaches till the nipple. Now, what is critically important here for you to know? The concept of TDLU. What is TDLU? TDLU stands for terminal ductal lobular unit. Okay, that is also called as the functional unit of the breast. Functional unit of breast. First MCQ, which is the functional unit of the breast, it is TDLU. What is this TDLU made up of? Now, we saw this in this image here, that first was this entire lobule, plus we had the interlobular terminal duct and this portion of the extralobular terminal duct. So this would be lobule plus ITD plus ETD. Got it? This is your TDLU, terminal duct lobular unit. So we will fill it up here as well. So it is made up of lobule. It is made up of what two other structures? Intralobular terminal duct and the extralobular terminal duct. So this also can be asked in your examination. What all are the components of TDLU? Now, it is the most active part of the breast tissue, and one more thing that you need to remember is that majority of the breast diseases originate from this functional unit, including your cancers. Okay, so most breast diseases including cancers originate or arise from the TDLU. Now, this TDLU is responsive to hormones, especially estrogen, progesterone, prolactin, and your growth hormone. Okay, so this is about the terminal duct lobular unit. Now, moving ahead, one more point that you need to know is that 50% of your ductolobular unit is located in which part? We remember that majority of the breast tissue, because it was extending right up to the axilla, was located in which quadrant? It was in the upper outer quadrant, and the 20% was in the central region. So, because majority of the breast tissue is present in these two regions, what will be the areas where you have to put special emphasis when you are doing breast examination? Again, it would be the upper outer quadrant. It will be the retroareolar region, and it will be the nipple-areola complex. Okay, so these three are the regions in which you have to pay special emphasis while doing breast examination. Now, coming on to the supporting tissue, we have already discussed the ductolobular tissue. Now, we'll discuss about the supporting tissue. First, let us understand what all are the supporting tissue other than the adipose tissue, the nerves, the lymphatics, and the blood vessels. One which is most important is the suspensory ligament of Cooper. This is an area from which a lot of questions have been asked. A small, simple structure, but a potential area for lot of MCQ points. Suspensory ligament of Cooper. Okay. Now, suspensory ligament of Cooper, what is it? First of all, we need to know that suspensory ligament of Cooper, it's a fibrocollagenous septa which extends from, see, where is it extending from? Look at this image. It is extending from the skin or the dermis portion right up till the pectoral fascia. Very, very important point. From the dermis to pectoral fascia. If you remember this point, rest everything that we'll discuss now is going to become easy. That the extension is from dermis to the pectoral fascia. Now, please understand, suppose if this suspensory ligament of Cooper gets involved, what will happen? It will pull the dermis towards itself, okay? See, pectoral fascia is fixed where it attaches inside, okay? If this ligament gets involved by some means and there is fibrosis or pull in this ligament, it is going to pull the skin of the breast inside, and this is what we call as dimpling or puckering. Now, what is the difference between dimpling and puckering has been asked. First thing is dimpling, okay? Dimpling. We all know what's a dimple, right? Dimpling is due to involvement of one ligament of Cooper. That is, if single ligament gets involved, there is dimpling. But if many ligaments get involved, an entire portion of the skin can be pulled in, and that is what we call as puckering or teethering. This is due to involvement of many ligament of Cooper, not just one ligament of Cooper. Okay, but please understand one thing. what is happening here is that there is involvement of the ligament. Is the skin of the breast or the skin overlying the breast directly getting involved? No, the cancer has not directly involved the skin. It has involved the ligament, which is causing these two findings. Okay, so can you call this as a skin involvement in breast cancer? No, it is not a skin involvement, and this is the point which they have particularly stressed about in many exams. Okay, so please remember this: not or does not qualify as skin involvement in breast cancer. Okay, very important point to remember, that does not qualify as a skin involvement. When this happens, what is the stage right now? Please remember, it is the T4B stage. We will be hammering this concept repeatedly because this is very frequently asked. They ask you which is the stage in which skin involvement happens and what exactly is meant by skin involvement. So the skin involvement is happening in T4B stage. Alright, now moving on to the next important finding is nipple retraction. Retraction always happens in the nipple, not in the skin surrounding it. Nipple retraction, involvement of lactiferous ducts. Okay, now what happens is, because what happens here is that there is fibrosis around the lactiferous ducts inside as well as around. So it is going to cause a pull or stretch onto the nipple, and the nipple is going to be pulled inside. This is not inversion. Please understand, this is retraction. There is a difference between the two. So there is fibrosis in and around the lactiferous ducts, which leads to nipple retraction. Now, next thing that you need to know with respect to nipple retraction is that it is of two types. Either it can be of transverse slit or fish mouth type of retraction, or it can be a circumferential retraction. When it is a fish mouth or a transverse slit type of retraction, it is because of two causes. First, periductal mastitis. We will be reading what this topic is, what this pathology is. Right now, just remember that it is because of periductal mastitis, which also happens to be the most common cause of long-standing nipple retraction. From the name itself, what does it mean? That around the ducts there is inflammation, periductal mastitis. Okay. Next, what can be the reason for this is duct ectasia. Again, what is an ectatic structure? Structure which has undergone dilatation is ectatic. So when a duct dilates, it is what we call as duct ectasia. So two causes for the transverse slit-like or fish mouth retraction. Now, what is the reason for circumferential retraction? It is cancer. Okay. Now, what is more important than the circumferential retraction is that retraction here is of recent onset. So, if the question is mentioning that retraction has happened recently within a short duration of time and it is circumferential, this is more suggestive of a carcinoma. Alright. So, this is about nipple retraction. Again, nipple retraction is involving the skin. No, it is only specific to nipple. So, nipple retraction is also not a sign of skin involvement. So till now we have ruled out dimpling, we have ruled out puckering, and we have now ruled out nipple retraction. Now let us read about the next important sign, which is very famous and very liked by all the examiners, repeatedly has been asked, but you need to know simple concepts and you're going to get the question right. It is called as peau d'orange appearance, that is orange peel appearance. The breast looks like, or the surface of breast looks like an orange peel. Orange peel appearance. For your ease of understanding, you look at this orange, it is somewhat like the orange peel. What exactly does it indicate? It is a sign of a locally advanced disease. Sign of locally advanced disease. What two things are happening in peau d'orange? There is edema plus pitting. Okay, so there is edema, there is swelling, and there is pitting which is happening. This occurs due to very, very important point. This has been asked twice or thrice in the examination. It is due to involvement of superficial or subdermal lymphatics. Superficial or subdermal lymphatics. Okay. So what can be the two causes? Involvement of which structure? Superficial or the subdermal lymphatics. This is one question. Another question or another way of asking the same thing is that when there is obstruction of cutaneous lymphatics, or you can also say that there is infiltration of subdermal lymphatics or axillary nodes. So please remember two things they've already asked. It was superficial or subdermal, cutaneous, subdermal. Even if the axillary nodes are infiltrated and the lymph cannot be drained, there is blockage to the lymph drainage, then also you can have a peau d'orange appearance. Okay. Now it is a sign of, this is where we finally get the answer that we've been waiting for. It is the sign of skin involvement in breast cancer. अभी तक सब नहीं थे. कौन से नहीं थे? Dimpling, puckering and nipple retraction were not the signs. This is the sign of skin involvement. Very important. Sign of skin involvement in breast cancer. And it is reflective of which stage? It is reflective of T4B stage. Now, along with this, just let us read about two other signs of skin involvement. They are ulceration and macroscopic satellite nodules. These two are also the signs of skin involvement. When present, the tumor qualifies as T4B. Okay, all right. Now, a question that was asked very recently, suppose if 1/3 or more than 1/3 of the breast gets involved with a peau d'orange appearance, what is this condition? This is your inflammatory breast cancer. Inflammatory breast cancer. You can see the image here. There is a big chunk of the breast, more than 1/3 of the breast, which has been involved by the peau d'orange appearance, and therefore this is your inflammatory breast cancer. Okay. Now, let us talk or discuss few important pointers about the nipple-areola complex. First of all, it is made up of what? It is made up of involuntary muscles. It contains involuntary muscles. Which two muscles? Okay, now before we move ahead with the name of the muscles, please remember that this is an update in the 28th edition of Bailey and Love, which was not there in the earlier edition. So please remember these two things. Circular muscles, we call them as Sappi's muscle. They are responsible for the nipple erection nipple erection, and the longitudinal ones are called as Meyerhold's muscle, which is responsible for retraction of nipple. Retraction of nipple. Let us highlight this thing. This is your potential MCQ block. Okay, the name of the muscles will be asked. You will be expected to answer based on the new thing that has been added in Bailey and Love. Okay, so this becomes your POMT, potential MCQ topic. Okay, now what other structure that you need to know about is Montgomery tubercles. It's a very famous thing already known that the sebaceous glands, sweat glands and accessory glands present in the region of the nipple, they become enlarged during pregnancy and they are called as Montgomery tubercles. One more point that you need to remember about them is that they lubricate the nipple during lactation. This is the function of Montgomery tubercles, that also you should know. Okay. Another thing, one last named structure is Toker's cell, T-O-K-E-R, Toker's cell. These are the cells of normal nipple epidermis, but there is a catch here. They are HER2 new negative by default because they are normal cells, but it is believed that these cells, they are also CK7 positive, cytokeratin 7 positive. They are the precursors for what? For Paget cells. It is believed that they are the precursors of Paget cell, and these Paget cells are HER2 new positive. Okay, so therefore these Toker cells are also an important thing to remember, precursors of Paget cells, and they are HER2 negative, whereas Paget cells are HER2 new positive. Okay, moving on to the lymphatic drainage of breast, a very, very important area from this module. Every year, 1 or 2 questions can be expected based on the lymphatic drainage of the breast. Now, simple things first. About 85% of the lymphatic drainage goes to the axillary lymph nodes, whereas only the 15% of it goes into the internal mammary lymph node. Now, let us write it down. 85% goes into the axillary lymph nodes, whereas 15% goes into the internal mammary lymph nodes. Internal mammary lymph nodes. Now, axillary lymph nodes have been classified based on the anatomical principles as well as based on the surgical concepts. Okay, now first let us read about the anatomical classification of the axillary lymph nodes. Now, the first one is the lateral nodes, which are located along the axillary vein, and they lie lateral to thoracodorsal pedicle. Okay. Next, after lateral nodes is your anterior or the pectoral nodes. Very, very important point that they are the sentinel nodes. In most patients of breast cancer. Okay. Now, what are sentinel nodes? We'll discuss in a very short while from now. Okay. Now, let us move on ahead first. Posterior group, which lies along the subscapular and thoracodorsal vessels. Subscapular and thoracodorsal vessels. Central and the medial group, which lies deep into the axilla, and the last one is your interpectoral nodes, which we also call as the Rotter's nodes. This is also important. The name Rotter's nodes has been asked that which are the Rotter's nodes. The interpectoral nodes are called as Rotter's nodes, and they lie between pectoralis major and pectoralis minor. They lie between the tendons of pectoralis major and pectoralis minor, whereas the apical nodes lie above and medial to pectoralis minor muscle, pectoralis minor muscle, and obviously lateral to the first rib. Now, what is the drainage flow like? How does the lymph go from the breast to the axillary lymph nodes? All the other than the apical nodes drain into the apical node. All the axillary nodes drain into the apical node, which further drain into the supraclavicular nodes, which then drain into the subclavian trunk. So, this is the flow of lymph that happens in the breast. Now, the question that is asked is often based on the surgical distribution or surgical classification of axillary lymph nodes. This is based on the relation of these lymph nodes to pectoralis minor muscle. Pectoralis minor muscle. Now, level 1 is the nodes which are located, look at this, this is level 1, where is it located? Below and lateral, located below and lateral to the pectoralis minor muscle, okay, below and lateral to P minor muscle. Now, level 2, please remember, you often recall it being just below, it is both above or in front or below the pectoralis minor muscle, both qualify as level 2. It includes, very important, it includes the Rotter's nodes. This is an important topic. This is an important question that has been asked. Rotter's nodes belong to the level 2 group of axillary lymph nodes. And what is level 3? From the diagram itself, it is self-evident that those that lie above and medial, above, see, this is above and medial, in front and below was level 2, above and medial to pectoralis minor was your level 3 nodes, okay. Now, what all comes into level 3 nodes? Okay, so level 3 is above and medial to the pectoralis minor. So, level 3 lymph nodes were above and medial to the pectoralis minor muscle. Now, what happens to the medial part of the breast? Where does it drain? It drains into the internal mammary lymph nodes. It drains into the internal mammary lymph nodes. Now, one thing which is very peculiar that I want you to know here is that now medial half of the breast drains into the internal mammary lymph nodes. Now, moving on to the next topic that we just had studied about was the sentinel lymph node biopsy. We just read that the anterior or the pectoral group of lymph nodes were the sentinel lymph nodes for a patient of breast cancer. Now, what exactly is meant by a sentinel lymph node? The word sentinel in practicality means a guard, okay. So, that is the first lymph node or the first echelon node that receives the lymphatic drainage from a diseased breast, or it marks the entry of the lymph into a region which is axilla here. So, for breast cancer or for breast region, the first echelon or the first sentinel lymph node is your anterior or pectoral group of lymph nodes. Now, what is the significance of this node? Suppose if you inject a dye into the tumor and if the tumor has metastasized to the lymph nodes, the dye will spread along the lymphatic channels. First, it will be reaching which node? The sentinel lymph node, because that is the first node receiving the supply or the lymphatic drainage from the cancer, okay. So, if the dye is reaching that lymph node or the sentinel lymph node, that means the lymphatic metastasis has already taken place, and that is what is the importance of the sentinel lymph node biopsy. How do we do it? We first inject, okay. So, let us read it once. It is the first echelon or the first lymph node to be involved. We inject a dye into the tumor substance. The moment it is injected into a tumor substance, we then, while we are operating, or we detect it with a handheld gamma camera, okay. A blue dye is injected. Which of the blue dye? A patent blue or a methylene blue dye, which is tagged along with a radio labeled substance, mostly technetium 99M, okay. Albumin or sulfur colloid or antimony is tagged. Now, other than this, what can be used? We can also use fluorescent dyes like fluorescein and methylene, fluorescein and indocyanine green. These two dyes can also be used for sentinel lymph node biopsy. Okay, now what particularly you need to remember about these two dyes are, when you use fluorescent and methylene blue, the identification rate of sentinel lymph node is about 90% identification. Sentinel lymph node identification rate is more than 90%. But if you are using indocyanine green, this approaches to 95 to 100%. Okay, so this is what you need to remember from the perspective of examinations, that indocyanine green is comparatively more effective in identifying the sentinel lymph nodes involved. Okay, all right. Now, this is what the concept of sentinel lymph node biopsy was, that I told you, that if, which is sentinel node, which is the first node to be involved from a tumor, once you inject and that tumor or that lymph node turns out to be blue, that means the lymphatic metastasis is taking place and the channel has been established. So it shows the metastasis. So what are the chances of other nodes also to be involved? Yes, there are significant chances, and therefore you will need axillary dissection in such a patient. But if there is no metastasis that has taken place, that means there is a very less likelihood of metastasis to be taking place with the other lymph nodes as well, because that is the gatekeeper. If that is not involved, the chances of the others which are behind it are less likely also. So you don't need to go for an axillary dissection in such patient. I hope you got what I'm trying to tell you. Okay. Now, after the anatomy, let us read about the physiology of breast. Basically, there are only few pointers with respect to this topic that you need to remember. Not a lot has been asked or can be potentially asked. So, only the pointers which are important I'm discussing here. First of all, what is the role of estrogen? Estrogen initiates the ductal development. Very important. So, the ductal development takes place because of estrogen. What is progesterone responsible for? It is responsible for the differentiation of epithelium and for lobular development. So, ductal was estrogen and lobular was progesterone. Alright, what does prolactin do? We all know prolactin is the hormone responsible for lactogenesis. Lactogenesis in the late pregnancy and postpartum period. One more hormone which is important is oxytocin. Why? Because it initiates the contraction of which cells? Myoepithelial cells, which are the contractile cells. Myoepithelial cells. When the myoepithelial cells surrounding the lactiferous ducts contract, there is compression of the alveoli. When the alveoli compress, what happens? The milk is pushed into the lactiferous sinuses. And thereby the milk is expressed out of the nipple because of oxytocin. Now, the key point here which you must have known beforehand as well is that the stimulus for oxytocin release occurs due to which all type of stimuli? Auditory, visual, and even olfactory stimuli associated with nursing. So, if the baby is hungry and crying, that cry can also stimulate a let down reflex in a mother. Therefore, you need to remember that oxytocin can be stimulated by three stimuli: auditory, visual, as well as olfactory. Okay, moving on to the MCQs that are based on this module. We have completed the theory part of this module. Let us solve the MCQs here. First MCQ: which of the following is not true regarding lymphatic drainage of breast? What is being asked? Which is not true. Okay. So, first option says level 3 nodes includes the Rotter's nodes. Is it true? Do the Rotter's node fall into the level 2 category? Let us remember it first and then solve the other options. Rotter's nodes were the ones that belong to level 2, not to level 3. Okay. Next one. Anterior axillary nodes are the sentinel nodes. Yes, anterior or the pectoral group were the sentinel nodes. All right. Majority of the lymphatic drainage from the breast goes to axillary lymph node. Yes, that is true. How much? 85% goes into axillary and 15 goes into internal mammary. Okay. Last option, apical nodes drain into supraclavicular. True, which further drains into the subclavian nodes. Okay. So the answer to this question is A. That is, Rotter's nodes belong to level 3, which is false. It belongs to level 2. Next question. Nipple inversion is due to the involvement of, okay, first subareolar duct, Cooper's ligament, parenchyma of the breast and subdermal lymphatics. Now let us take a 10-second thought into what exactly did we study some time back. Nipple inversion we are talking about, not retraction. If the question was saying retraction, nipple retraction, then the answer was what? It would have been lactiferous ducts. But we are talking about nipple inversion here. Okay, so this option gets ruled out. About the parenchyma of the breast gets ruled out. What happens in inversion? We said that the lactiferous ducts were not able to reach where it were not able to reach the surface, or the elongation of the lactiferous ducts was defective. Therefore, what happened? They remained subareolar. This is what we had read, that the ducts remained subareolar, and this was what was responsible for nipple inversion. So the answer to this question is A, that is subareolar duct. Okay, all right. Next question. Dimpling in breast carcinoma is due to, we just read about two phenomena, dimpling and puckering or teethering. Both of them were because of the involvement of Cooper's ligament, contraction of Cooper's ligament. That is the correct answer. Subdermal lymphangitis, no. Scarring, no. Edema, no. Edema and pitting happens in Peau-d'orange appearance. Subdermal lymphatics are usually involved in cases of, again, Peau-d'orange appearance is the one which is caused due to the involvement of subdermal lymphatics. But dimpling, again, Cooper's ligaments are involved here. This was all about the anatomy and the physiology of breast. I hope you have understood the concept that I've given you. Please solve the MCQs corresponding to it, which will be applied now in the further modules that we'll be discussing on breast. Before I wrap up, I want to tell you one thing, all this effort that you're putting in, if you are not supplementing these efforts with timely revision. Now, timely revision does not mean that you particularly set a date for revision. Again, I'm emphasizing revision always goes along with the reading. It is not a secondary date that is set for revision. It is revision. You see what you have read again within a short duration of time. If you follow this golden principle that revision happens simultaneously, rest be assured, that your ranks will automatically shoot up without any extra effort. You don't have to work extraordinarily hard to do that. Simultaneously read, revise within a short duration of time, and that matter will get cemented in your brain. Okay, thank you.